Welcome to the Be Still, Be Aware series, where nothing is off limits. I'm your host, Claire Foord. Let's talk. Hi there. Thanks for joining us for the Be Still, Be Aware series. We're going to be talking about research, what is happening in Australia, research that works, and how we can connect the dots in care to be able to benefit the community, and how you can benefit from understanding what the research tells us to have a safer pregnancy and a better outcome. I'm joined by Professor Vicki Flenady from the Stillbirth CRE and the Mater Research Institute in Queensland, from the Stillbirth Foundation Australia, Leigh Brezler, and then also from Monash University's Ritchie Institute, Dr Miranda Davies-Tuck. So thanks for joining us, and let's talk.
Before we begin, we'd like to acknowledge the traditional owners of the land on which this series is recorded and pay our respects to their elders, past, present and emerging.
Thanks so much for joining us, everybody. And with us today, we've got lots of fabulous people in the room from all over Australia. I might start with Leigh Brezler from the Stillbirth Foundation. Do you mind just introducing yourself and telling us a little bit about the Stillbirth Foundation and I suppose the research side of the importance of stillbirth research?
Yeah, sure. Thanks, first of all, Claire, for having me on, and hello to Vicki and Miranda. My name is Leigh. I'm the CEO of the Stillbirth Foundation. We were founded in 2005 by Emma McLeod, whose daughter was stillborn, and she couldn't find any answers or any reasons and really wanted to start a foundation to invest in research effectively. So we say our research is in our DNA. It's really the purpose of why we started. And funding research is so important to parents to find reasons why their babies were stillborn. And since 2009, which is when we started officially funding research, Foundation has funded over $1.4 million in stillbirth research.
Amazing. And I think, probably that flows straight into, let's say, Professor Vicki Flenady, because some of that research, I think, is that there's quite a bit of a crossover with the partnership that you have with the Stillbirth Centre for Research Excellence. And Vicki, I wonder if you want to introduce yourself and the centre itself.
Oh, hi. Thanks so much for having me, Claire. Yes, so Vicki Flenady, I'm the co-director of the Centre for Research Excellence in Stillbirth, and we're based here at the Mater University of Queensland campus in Brisbane, but a national entity, as many would know. I think that the Stillbirth CRE has been a long journey. We started, I suppose, working in earnest in this space almost 30 years ago as part of the Perinatal Society of Australia and New Zealand. And so, and developed the first national guideline on care after stillbirth, including investigations and respectful care. So yeah, it's been a long journey and really exciting over the last 5 or 10 years with stillbirth really coming out of the shadows with a lot of the work that we've all done together across the country. So yes, we're in our 5th year almost now of operations as a Centre for Research Excellence, funded by NHMRC. We're going back and asking for some more money to keep us going because we believe we're just starting to really make some inroads and some really important research, new research, but also implementation research as well. So taking what we know and implementing it in everyday practice to improve outcomes for mothers and families and to get those numbers down. Our target is to reduce stillbirth by 20% over the next few years as part of our national initiative of the Safer Baby Bundle. We can talk about that a little bit more.
So on that, we'll talk about obviously the ambition to reduce stillbirth by 20%, but and why that came to be and where it came from, and also what's happening overseas. But before we do, I wonder if Miranda or Dr. Davies-Tuck, whether you want to introduce yourself and where you fit into the mix of research.
Yes. So hi, everyone who's listening. I'm a perinatal epidemiologist and I'm based down in Melbourne at the Ritchie Centre. So that's, we would say, Victoria's preeminent mothers and babies research institute. And I work within guess we call it the Clinical Epidemiology and Clinical Trials Group. And I joined the Ritchie Centre back in 2012. And so my background is public health, epidemiology, biostatistics. And I was really interested in joining the Ritchie Centre because I was quite shocked with the disparities in maternity care that I experienced and my friends experienced back when we were having our children, and really the lack of evidence around some of the things that women were offered during their pregnancies. And so I started there in 2012, and one of the first things that I noticed when I started to get involved with the group was the disparities in stillbirth. And I was quite shocked to learn that there are women in Australia who have access to our healthcare system that don't have the same outcomes as everyone else. And it kind of really disgusted me almost. And I thought this is somewhere that we can make a really big difference to improve outcomes. And so I spent the last, 8 years now working in that space to try and target groups that experience high rates of stillbirth so that we can prevent it from happening.
And while you're talking about that, I mean, that's a great story as to why you got into the research and why it's so important, because I think for those who are listening and watching this series may not even understand quite what the levels of stillbirth and I suppose the disparities in care as well. You talked about those that experience high levels of stillbirth. Who is that group and what are we talking about? Is it everybody? Is it the whole of Australia, or is it particularly pinpointed areas that you're more so looking at, Miranda?
Yeah, so I think if we look at the national statistics, Australia as a whole is actually really, really good. We're obviously not the best performing country, but overall we do really well. But when you knuckle it down and have a look at different groups of women or different areas in Australia, we start to see some of those differences in stillbirth rates. So where I am located in Melbourne, we have a very large migrant population, and the health service that the research institute that I'm based at has a very large population of women who are of South Asian backgrounds. So these are predominantly women who've come to Australia from India, Afghanistan, Sri Lanka. And we noticed at our health service that this group of women were experiencing stillbirth, particularly at the end of pregnancy, at double the rate of everybody else. It's just kind of shocking, really, to think double the rate of women sitting in the room giving birth next door, receiving the same antenatal care, who live in the same catchment area. And so my work has predominantly been focused on looking at those disparities and a large focus on South Asian women. Migration to Australia and particularly Victoria is increasing, and we're also seeing now that women who are born in Africa also are probably a group that we really need some more focused research attention on, because their rates of stillbirth are higher, sort of the magnitude of 50% up to double, depending on when in pregnancy you're looking at. So that's the group that I focus on, but there are other groups such as Indigenous women that also experience high rates of stillbirth in Australia.
So while you're talking about that, Miranda, those particular women, in case there is anybody who is of South Asian descent or of African descent for that matter, who's listening or watching this series, what can we say to them to help them feel confident in their care, because like you said, the disparity is there, but the care is equal. So what do they need to be doing in their latter part of pregnancy, and perhaps what do their care providers need to be doing? What do we need to tell them, or those that are listening that have friends or family that are in those demographics or those groups? What do we need to be saying?
Yeah, I think it's really important to keep in mind that these were the observations that I made back in 2012, 13, 14. And if we have a look particularly in Victoria at the rates of stillbirth amongst women of South Asian background, we've seen those rates fall in Victoria. And I think we've got some data to show that those rates have started to fall in New South Wales also. And I would like to think that it's a lot to do with the research that I've been doing over the past 8 years that has identified a potential target in pregnancy where we can focus care and attention to pick up those babies that are at risk. I think just increased knowledge amongst all clinicians, midwives, women, the general community, that there may be an increased risk. There's a lot of work done over a decade ago around the importance of understanding babies that are small are at risk of stillbirth, and simply better acknowledgement of a risk factor reduces those rates of stillbirth. But I think the clinicians now and the health services have a really good understanding across Australia that women of South Asian background do sometimes experience higher rates of stillbirth, and there is an increased attention and focus on those women's pregnancies at the end. In Victoria, we do one particular thing, but I know that across other hospitals and other jurisdictions, that awareness has also filtered into their change in practice. Mm-hmm. They might not do exactly the same things as us in Victoria, but I think we're seeing that targeted focus at the end of pregnancy for South Asian women. So if you are of South Asian background, whether you're born in South Asia or your family origins are South Asian, I would expect there'd be conversations happening at the end of pregnancy around 37, 38, 39 weeks to discuss that risk and different options put on the table for women of that background to make some choices around when their babies might be needing to be born to reduce that risk.
And I know we've been asked about that from a perspective of whether it's maternal or also paternal, but I understand that it's purely a study that focused on maternal ethnic origins, yes?
Yeah, so the challenge that we have is that the way we collect data at a population level, we don't collect that paternal information. I think we need to get to a point where we can collect that, but because it's not there, we can't make that comment. Mm. I guess I'm not sure whether it matters if we've got if we've got some form of clinical care. I think if the father is of South Asian background and the mother's not, it would make sense to offer that same intervention as you would offer someone if it was just the mother or both the mother and the father. So I think it's just a general awareness, I guess, that can hopefully the clinicians at the day can make those calls knowing that there is an increased risk.
Now, you touched on data very briefly then, and that will probably link into a question that I'm going to ask you, Leigh, in relation to data and a potential delay in data. I know that some people who are listening and watching now have probably heard you recently in conversations around the delay in data. What can we do about that? And I suppose, is there a delay in data in Australia, and is there a way that we can be collecting it better?
So we're looking now at nearly the end of 2020, and the AIHW data on stillbirth rates is from the most recent information we have is from 2017 that's been published. So one of the recommendations from the Senate inquiry back in 2018 was better access to data collection and more timely data to allow us to really judge if and how these interventions are working and not have that sort of 3-year time lag. So yes, I think it is very important if we can know what the COVID rates are for each state yesterday, how can we not, assemble some timely quality data around, stillbirth rates, with minus a 3-year time lag. So that's one of the things that we're sort of focused on. And again, in partnership with SDRE, is really looking at how we can improve data collection. Obviously, each state and territory has its own data collection mechanism. And while I'm no data expert, I do think that one of, the end goal is really to have, as we can demonstrate with having up-to-date, again, COVID numbers, let's find a way to really improve this robustness and the timeliness of the data collection. I'm sure Vicki and Miranda both have some probably much more scientific-based opinions than I do on that, but I do think it's incredibly important. Absolutely.
I would assume it's important as well for the people that are supporting the Stillbirth Foundation. I certainly know from Still Aware's perspective, whilst we have our own lived experiences, from a perspective of information, data analysis, that can potentially give us more understanding and more knowledge if we have the information in front of us to go with, right? Do you find that some of the people that support your organisation are asking for that or asking for numbers and want to know more information, and it's hard to be able to give them, you say, well, we'll know in 4 years' time what those numbers were this year?
Yeah, look, it certainly is. I think we find that our supporters who fund research, they ultimately want to know what the outcomes are in a timely manner, absolutely. And I think there's something in the act of giving to a cause that kind of helps them through their stories and helps them know that they're putting their money and they're helping to make a difference. So absolutely, the sooner we can tell them what difference they're making and how that is. I mean, I know we funded, I think, part of Miranda's study into the South Asian women ages ago. So, the fact that we can actually sit here and have a conversation years and years later where we have seen positive results is incredibly promising. And that, I believe, is the goal of all of our supporters, as we are 100% community funded, to be able to know what those outcomes are and how we're achieving what we're setting out to achieve.
Absolutely. And Vicki, I think it would, potentially go without saying that we need the research. To get the research, we need the data, timely, right? What's your position on that from the CRE's perspective? What I know that you're working closely with government through not just the Safer Baby Bundle, but the action plan and taking the advice from that. And one of those items, which I know that Leigh just alluded to then, was data in a more timely manner. Is there any updates that you can give us from that perspective, or even on the importance of data to inform, where to next?
Thanks, Claire. I concur with everything that Leigh has just said. It's so vitally important to get these data faster, and I really appreciate your analogy there with COVID. We know that COVID numbers overnight, why don't we know when a baby dies? I suppose AIHW produced a report in May 2020 this year for babies who died in the year 2018. We're getting a little bit better, but it's still a long delay. And it's not only numbers we need. We need to know a little bit more detail about every case very quickly to be able to react appropriately to reduce the risk. There are some cases where there's systems issues that need to be fixed quickly. We've got Victoria's another example there of initiatives to really, they're highlighted the importance of initiatives to monitor perinatal deaths in a more granular way and undertake audit to understand the circumstances surrounding those deaths. So I think every baby counts. Every baby that dies, we need to learn from, and we need to learn from them quickly. We can't look at data 18 months, 2 years later. We may have had a whole stream of babies lost because of issues that we could have intervened and reduce the risk. So one of our new programs within the Sorry, when we're talking about babies that die, this is 6 babies a day that we're talking about, and so it's not not numbers that are small by any means. Although the fact is, we are doing well as a country, we can always do better. So you mentioned that's one of the initiatives that you're working on at the moment, Vicki. Before I rudely interrupted you, you were going to say something about one of the programs that you're working on. Yeah, so one of the programs is Data to Drive Change, I think we've called it now, Miranda and Leigh, haven't we? we called it in the previous iteration Understanding Causes and something or other, I don't know. But it really is about data driving change. And we need that data quickly if we're going to make changes to reduce the numbers of babies. Every day, 6 babies. So let's, it's not rocket science. It shouldn't be as hard as it seems to be, but it's ownership of that data by the clinical services, their own data, be able to access what is happening in my service, being supported and having a framework to be able to make those changes. So it's not, AIHW do a great job in reporting statistics. We need different kind of data. We need to hear from the parents about their experiences, and we need to look at all the investigations and need to put the whole picture together on every baby that dies to understand how we can prevent the next potential loss. Yeah.
And you talked then about the babies that die and hearing from a parent's experience, which I think is so incredibly valid. And certainly there is so much that the parent and the expert can do together in being experts themselves in their own journey. I think as well, it might be pertinent to talk about the near misses, because we don't have any way of, at this stage, as far as I'm aware, calculating those. We just say, oh, great, the baby's alive, so all is well. But that doesn't count into the potential levels of trauma, as well as the fact that that baby may be alive but very, very sick, or alternatively alive fighting for its life, or alive and then soon after not alive anymore because of the care or the situation in pregnancy. So an alive baby isn't the only answer we want, right? We want that antenatal care, like you alluded to, Miranda, before, in terms of, well, hang on, even though we don't know if it's maternal or paternal, or we don't know the paternal standing on that, relating to that information that you have ascertained through your research, it doesn't mean that we can't actually just have the conversation regardless of where dad or mum comes from. So what's your take on that, from a Victorian perspective, Miranda, and, having the research that you just talked about before go into practice, and how do we do that? How do we turn this data into evidence that can inform practice, and how do we communicate that with the care providers so that we can see those changes?
I guess the key is that what needs to happen needs to come from the service level. So I think the work around reducing stillbirth in South Asian women in Victoria has been so successful in terms of implementation is because it was a problem that the service had that they wanted help to solve. So it wasn't researchers or people sitting up in government saying the rates are too high, you need to fix it. It was them sitting there reviewing their deaths, as health services do, and saying, my goodness, these are all women of Indian background. What do we do? And we need someone that has some expertise in understanding data, and someone who knows how to bring together some of the bigger data systems, because one service, you're never going to get enough data to understand trends, and then going back to them and with that partnership and saying, this is what we think's going on, this is what we think we could try, we're going to suggest this practice change, we're going to get money ourselves. So this wasn't paid for by the service, this was a grant that I got. There was a Stillbirth Foundation grant, then there was also a Red Nose Foundation grant that helped us fund implementing it, and there was buy-in from the service. It was and then we've finished, we've analysed it all, we've captured what the midwives and the doctors experienced. We've got clinical outcomes, we're now speaking to women, and all of the data that we will collect will meet the needs of the different groups, which will then help us implement further. So I guess it needs to come from the bottom. We need to be embedded in the services, or speaking to the families, or speaking to the community groups, or whatever it might be that's faced with that challenge, answering their question and then giving it back to them so that they can take it and own it and move it forward and, help monitor, evaluate, refine, whatever that might be.
And it sounds like there's two levels of very important buy-in there. And, it's a great example of community working with care provider, right? So you've got buy-in from the community whose outcomes are poor, and you've got buy-in from the healthcare provider, making sure that we can work together as a team to effectively enact that change, but using information that is informed through data collection and research and actual fact. I think, that's a terrific analogy of how something can work so cohesively and well. So why doesn't it always happen that way, Vicki? If we go to some of the things that have worked and some that haven't, what's holding it up? What is it? Is it a care provider issue? Is it the fact that we're not reaching the consumer early enough, or the community, and we're not speaking to parents? How can we make this more cohesive and collaborate more cohesively so that we can all enact change effectively? Because it's not all, as Miranda just described, a very a unified experience that we go, well, that should just be that simple. But why isn't it? Is that a hard question?
It is a hard question, but I'm just going to narrow it down a little bit, if I may. I think way back in 2009, the Perinatal Society developed guidelines about how to undertake in-depth audit of stillbirths and neonatal deaths to inform practice change. we're here in 2020. I had to look at my calendar to make sure what year I'm in. We haven't implemented in Australia a systematic approach to do that, nor the support systems and framework to allow services to do that properly. So countries like the Netherlands have done it very well. They've seen the biggest reductions in stillbirths. They started at a higher rate than we did in 2000, but they are fast catching up with us. And one of the things that, as we talked to Professor Jan Jaap-Urwijk, who set that up, one of the people, instrumental in setting that up in the Netherlands, says he thinks it's the perinatal mortality audit process that really drove that change. And it was not a top-down approach; it was a bottom-up. It was the services being supported to do what they want to do what they're there for. They come to work every day, the midwives and obstetricians and everybody else, to make sure women and babies are safe. But sometimes systems let them down. Sometimes they don't have the support to do what they want to do, or the training to be able to tackle these things effectively. So, I think services need, as Miranda said, it should come from the services. They need the support, as Miranda's model has showed, to, when they find a problem, how to tackle it, how to engage with all the key stakeholders, including absolutely critically the families, and to make change. But you need good data systems to be able to, as Miranda actually said as well, it's one service, it's very difficult to see the change because of the numbers. You need to combine services. If you doing the same things and collecting things in the same way, you can compare like with like. So collaboration is so important. A national data system that would be responsive and look at these to support services, to look at every death in a systematic way and combine data, particularly around risk factors. We know the other risk factors. We know the major risk factors, to see if women are receiving the care they should have received around those risk factors. Were there any systems failure involved? I don't know. Did I answer the question?
Yeah, you did. Can I just add to Vicki?
Yeah,
Can I add to Vicki's point that the data, what makes data good is when we start benchmarking.
Yes.
So I can't speak to the other jurisdictions, but in Victoria we have a bit of a competition between all of our services. So every year we report a report called the Perinatal Services Performance Indicators, and we have key outcomes for every single hospital in Victoria, and you can see what your hospital rates on all different parameters, including perinatal mortality, versus the others. And it does drive competition in a sense to strive for improvement, but it also identifies for us where services might do things really well. And we can go and have a look and say, well, why is this service's perinatal mortality rate so much less than equivalent capability levels, so the same sort of risk profile women? What are they doing differently that we can learn from? And I think the idea of data, we don't just want data available, we actually want people to be able to compare and contrast and maybe look at the hospital, 3 Ks down the road, 5 Ks down the road. Why is their perinatal mortality rate so much lower than ours? Let's get together, let's chat, we want to beat them in the next report. We want to be better than them in the next report. So the benchmarking is also really important.
Yeah, I mean, being able to compare apples with apples is so critically important. And yet we've got so many disparate data collection systems across this country. If I could just describe our experience with the My Babies movements, Claire, is that okay, and the data? So we have we undertook this trial over a 3-year period, looking at a fetal movement awareness package across 26 maternity services in Australia and New Zealand. And we thought, well, we need big numbers to be able to look at the outcome of stillbirth after 28 weeks gestation. Did awareness reduce the rate of that outcome? And we thought, well, how can we do this? How can we get the numbers and be able to afford to do this trial, because they're very expensive. we'll use routinely collected data. We won't set up a new data collection system and pay staff for collecting data again. We'll use every hospital's data collection system. That was made things very difficult. We had finally, with all the disparate systems, I think we had 77 data items as our core data set, and I think about 20 different data systems that we had to map. Most of the variables, over 70%, didn't match, so that we had to do enormous amount of mapping, enormous. If I had Cara Warrilow in the room with me now, she would be crying at the thought of it, because she was our data manager, and she was, it was a challenging task. But it just goes to show, we've got a long way to go. But the solutions are here. Most pregnancies, the data set is very easy. Most follow a very, very 90% of the time, it's fairly consistent. So it's not a hard data set to put together. And not only that, our primary outcome, stillbirth, was the messiest data, which was just shocking. There was different systems in the hospitals for recording stillbirths for the committees that reviewed the deaths versus the routine data, and they didn't talk to each other. So we spent 6 months going back to the hospitals trying to get the right data. So, I mean, we learned a lot from that, but it really showed, we've really got to clean up our act with data collection. Yeah.
And disparities in systems as well. I think you mentioned the systems issue being a problem. I mean, we look at, and what Miranda talked about in terms of the competition, that created not just competition, but actually collaboration.
Oh, yes.
That's not just about saying we're the best hospital, we're awesome, but hang on, how come they are the best hospital and how can we be better? Yeah. And created that buy-in that you talked about, Vicki, being needed in terms of, the services providers wanting to get in there and understand that their rates actually aren't that great, and it is a much bigger issue than what they are perceiving it to be or what they are fed to be told that it is from their own experience as a clinician. And in the same way, you talked about the fact that there was all of this messy, it was a mess, it sounds like, with you having to analyse all these different levels of data. Is there room in that then? Do we need to be looking at this from a higher level? We know what has worked or what has driven change in some different practices. Is this simply something that we can do, or rather it's not simple, because, you talked about something we've known for 11 years and still we're not doing well at it, even though we've, had data come out in 2009, we still aren't doing well at it yet, and we have a long way to go. But if it is a major systems issue, is this something where the federal government needs to step in and say, actually, we believe that everybody has to have the same level of data collection, the same way of categorising births, live births and unfortunate stillbirths, as well as near misses, so that we can actually look at all of this and really quantify, and in a quality way, what we are looking at properly, so that we can benefit the community. What do you think, Vicki?
Absolutely. I think it's got to be across the country. It needs federal government push to get that consistency. We do have the Australian Institute of Health and Welfare, who does work with the state and territory jurisdictions to get a minimum core data set that's consistent. We do that. And because it's so different and difficult, that's why we have such delays in our national report. So there is some good work going on, and AHW, their reports are improving, and they're, much more helpful, I think, to families and to clinicians providing care, much more informative. But the timeliness is an issue, and the narrow data set that they are able to use because of the disparate data collections across the country is a major limitation. We need one system. We're a country of 300,000 births. Come on. We're not that big. And yet we've got 8 different health departments. We can't go back and change that now, I suppose.
We can do better. If we want to, we can do better. But it does take, us being up in arms and creating that groundswell. So I suppose, from that, Leigh, you're talking about this this, in most people, I think, from the, looking from the outside in on this sort of research world, listening or watching this episode today, I don't think a lot of people would be aware of how different each system actually is. And I think, Miranda's take on the fact that they, have this, this constructive competition that creates collaboration and wanting to do and try better as a system. Do you think, Leigh, that would help to not only drive change, but for your, supporters and for the bereaved parents that want to understand where they can go post-loss to potentially have a pregnancy after loss, do you think that your supporters and the people that are involved in your community, they would seek something like that to be able to say, hang on, maybe these people are going to look after me better? Do you think that would work?
Absolutely. And I know, as Miranda and Vicki would have heard me say before, there are other systems that get it right, and there are other places that are doing things. I mean, the competition and the collaboration, if you live in Sydney in the North Shore and you want to look at the school systems, there is fierce competition between the schools. They publish their HSC results. This is a system that works in, may or may not be flawed, to have your opinions, but there are other systems that are creating this healthy competition where they know what their HSC results are for the last 5 years. They are benchmarked. They can see, who's going through that system and doing well. So if we had something like that, absolutely. I mean, when I had my kids, it was, who do you recommend? It was word of mouth. There was zero scientific approach to who was going to deliver my baby. I mean, that seems insane to me now, knowing what I know, that I just said, oh, who's that person? Oh, they're great. Okay. And you do a little vox pop and you ask people, no data to back it up, nothing. It was just, oh, that seems like a great place. So absolutely, if we had some more information and, that kind of gauge, where you can look on the website and go, yep, okay, that hospital gets a 95, perfect. The other thing, going back to the data collection, is really disrupting. Yes, we put a lot of faith in the AIHW and they do a great job and the reports are super thorough. What if we took that power back and we disrupted, we say, okay, bereaved parents, you tell us if you've, what your experience has been like. Did you have continuity of care? Did you have, we can come up with our own questions and ask parents, and we can find some way to speak to the parents who've had a near miss or have had a preemie baby. And, I think that there's some disruption. I feel like there's something we can do to take some of that power back, because then if and when we do, and come up with our own system, then maybe someone else will cotton on and take it and scale it, and we can, achieve really great results. So yes, the government is doing, as much as they can. Each state does have their own systems. What if we create our own that we can spread nationally? And, there's something in that. I don't know what it is, but disruption is happening in fintech. It's happening in, again, so many other industries and sectors. And it feels like this is something we can, take that power back.
And I think the community needs to be involved in this. We can all say, okay, so great, here's the results. But unless there's buy-in from the beginning and buy-in from everybody, which leads back to the study that worked, which we're talking about. I mean, there's lots that work and there's lots that don't, but research is great because you have an outcome regardless of what it is. We can actually have an answer and we can say, okay, so is this something we can use to help disseminate? We communicate with our broader community about this, but creating that groundswell, creating that community, and the disruption you're talking about, Leigh, is so important, I think, in this space of otherwise silence. We all live and breathe this, but from the viewer or the listener today watching this might be the first episode that they have chosen to listen in on. And this might be all very new and novel to them, in the fact that they go, what? Stillbirth is actually a thing. But, in your perspective, Leigh, I'd love it if you would just touch on what stillbirth actually is from the parent's perspective, from how it actually affects the greater community, that it isn't just a number. We're talking a lot about data. We're talking a lot about how we can enact change, but it needs a conversation, and we need to talk about it in pregnancy so that we can hopefully see this change. And a lot of this research is informing the discussion. But what do you think, what is stillbirth in the eyes of the bereaved?
It's so many things. It's, you know, it's if you have an early, you know, a 20 plus weeks, people saying it's not a stillbirth, is a stillbirth. So there's a definition of yes from 20 weeks. And then there's people that are saying, you know, we have stories of people saying, well, I still had to deliver my baby at 19 plus 5 weeks. So is that a stillbirth? So there's that kind of, what is it scientifically? And then there's what is it to the whole community, to the parents, to their family and friends, and to their other friends of childbearing age who are having their kids at the same time. It's a support network. It's people who rally around bereaved parents. It's also grandparents and people that just can't talk about it for years and years, and then decide that they're ready and they want to talk about it. And it's people that have had stillbirths 20 years ago or 40 years ago that say, you know, now I'm telling my story. And so it's so many things. It is an absolute devastation. And then it's the point before the loss and after the loss. So it's just builds. It's just the chasm, you know, it's the before and after. And really it's so many things that is unique to every person. Then it's how do you navigate pregnancy after loss? You know, I haven't articulated that very well, but the stories I've heard have, you know, from so many different families. It's heartbreaking, and really it shouldn't. Yes, you have congenital anomalies and you know, where we have preventable stillbirths, and we can tell people to sleep on their side, and we can tell people to monitor their baby's movements and to seek help immediately, and we can, if anything changes, and we can tell people to stop smoking during pregnancy, where we know that there are things that we can do to help hopefully prevent a stillbirth and reduce the risk factors. These are things that we should be telling everyone and shouting from the rooftops, because it's an absolute devastation.
And I mean, you know, for those families, and I think you did articulate the fact that it is not just a women's issue. This is not just a women's health issue. This isn't just the parents, who've experienced the loss, but it is the friends and the family and the grandparents and how that has affected them. This is the loss of a baby, of a child, and the moment before and after. This is heartbreaking, like you said, but it is the loss of life and so much the loss of a potential livelihood, of a way of being able to bring up and bring these children into the world. But in, some cruel way, there is this hope and this glimmer that we can save other babies' lives. And the cruel thing is that we haven't done well for such a long time, and we can do better. And when we know better, we're meant to do better. So we know better now, and so we really have to do better. And I think, Vicki, you're, through the Safer Baby Bundle, which you alluded to earlier on through the CRE, you're hoping to be able to enact some of that change through understanding the research and being able to disseminate that through the community. So did you want to talk about that a little bit as well?
Yeah, thanks, Claire. I think stillbirth is not a cause of death. I mean, it's multifactorial. A stillbirth is a baby without life, and there's a lot of pathways leading to that tragic event. And I suppose then, if we accept that, and that is a fact, then the prevention has to be multi-pronged. We've got to think of different ways, different interventions. We've targeted losses after 28 weeks gestation in the first instance in the Safer Baby Bundle, because they're a little bit more similar in the pathway, a lot more placental, underlying perhaps placental dysfunction, perhaps babies not growing so well, where you might get early warning signs, things aren't going so well, you might have an opportunity to get in there and help and avoid that stillbirth. That doesn't mean to say that stillbirths below 28 weeks are not important, but we've targeted the 28 weeks because we felt as though we've had some interventions we could go out with now to help that group of babies first. I think general awareness about stillbirth will help reduce the numbers across the board. But we are trickling down in that late gestation stillbirths. We've reduced from 2.7 per 1,000 in the Lancet series report of 2016 now to 2.2 in the last global estimates that just came out. So we need to feel good about that. We calculate the numbers of babies we've saved.
You're talking millions here.
Sorry, yes.
What we're saying? Yeah, 2.2.
Yeah, I mean, we've really, collectively, all our efforts, we are saving more babies now. So that is fantastic. But it gives us hope that we can do better. Talk about benchmarking. So if we benchmark against countries like Japan, Singapore, they're doing better than we are. So we know we can still do better. We can still reduce our rates of stillbirth. And we know by the audits that we do, of those hospitals that do actually in-depth audits, we see things that we've missed. And it's often around caring for women with subtle risk factors, and we haven't sort of put two and two together, or the woman hasn't been aware enough herself. So we know we can drive this down. So, so the Safer Baby Bundle, 5 key elements to, as Leigh mentioned, make sure women understand that sleeping on their side later in pregnancy is important. Being aware of decreased fetal movements, and Claire, still aware, you've done a lot of work in this area, and I think women are more and more aware, much more than they used to be 5 or 10 years ago, about the importance of decreased fetal movements. But we've still got some work to do. Women are still sitting home and delaying reporting. Our My Baby's Movements data showed that 40% of women sit home worrying for more than 24 hours. That's just recent data. So we're missing an important window of opportunity.
On that data, because you've looked, I think for those that are, those that are listening that are clinicians or expectant families, what are the risk factors for stillbirth, and what are some of the things that we can do about it? I mean, you've talked about settling on your side in that later part of pregnancy when you're sleeping, monitoring movements, but that delay, don't delay that response. That's very worrying, that 40% of women, delayed reporting a change in their baby's movements in pregnancy, for more than 24 hours. Wow, that is, and I suppose explain why it is so shocking for you to hear that, because from a medical perspective, Vicki, what do we understand that could be a sign when a baby is changing the way that they move or decreasing their movements?
I mean, it's a symptom of a baby who may not be well. It's a symptom. I'm leaning away from calling it a risk factor, because it's not like smoking. It's not like, advanced maternal age or, those risk factors. This is actually a symptom, like you get chest pain, and you might be having a heart attack, or you might just have indigestion, but it is a symptom of something that could be going wrong. So if you were having chest pain, you would go immediately to the hospital, immediately. And they might say, here, take this antacid, and you might feel great the next day. Or they may not. So most women who have the experience of decreased fetal movements or a change in the movements will go on to have a normal, healthy baby. We know that. But unfortunately, some women don't. And we know that group of women who have decreased fetal movements are 4 times more likely to have a stillborn baby. So it is a warning sign. And why don't women come in? They don't want to bother the service. Midwife's too busy. We don't, and it's probably, I think we need to have a better relationship with women during antenatal care. Done well in some sectors, it's in some places, not done well in others. But if a woman could say, oh, I feel good about ringing up Harry or Sally or whatever, I know they're not going to think I'm an idiot. They will ring up, you know all this, but it's so important. Don't feel silly. This is your baby. You're the mother. You're caring for your baby. Do what you do if your toddler had a high temperature or looked a bit floppy sitting in the lounge. Take them in to get checked out. So how do we get that down further? I think the work that's going on now that you're continuing to do, Claire, through the Safer Baby Bundle, getting those messages out, is really important. Come in, that's what the midwives and obstetricians are there for, and get checked out. I think it changed from about 60% of women in this cohort down to about 40% of women delaying 24 hours. So it did, the awareness did make some impact, but still that's too many women waiting. Yeah.
And that buy-in that we talked about before, is that the disconnect that, you know, it's not a cohesive unit, that we need to talk and we need to, like Leigh said, pass that power back and empower people. And, you know, like you just said, Vicki, you know, communicating, having a conversation and being part of that, and, you know, actually allowing people to know that they can go in, like to, I think you said Harry or Sally. You know, they've obviously communicated great to that woman. So we Harry and Sally.
That's right.
And I suppose, Miranda, you know, you started talking about the reason behind your desire to study or research more around stillbirth and the levels of care, because there were disparities in your care and your friend's care that you got in your pregnancy, and that concerned you. So I'd love to end our discussion today, you know, from a consumer perspective, what was missing for you, and what do you think that women and families, expectant families, deserve to be told, and how they should be cared for, in your opinion, as a mum and somebody who started her research journey because there was that series of differences between care provisions amongst you and your friends?
I think so. My children are 11 and 9, so my experience of the system was a long time ago. And certainly speaking to people who are having babies now, I think things have changed dramatically in the last decade in maternity care. I think women really are being put more to the front. You don't just sort of get told, this is what we do, this is what, you know, you're not allowed, you know, this is what happens. That doesn't happen so much anymore. And I'm seeing more and more that friends and family are being presented with risks, and they're being presented with options. So we think your baby's not growing. This is the accuracy around the measurement we've done. We could do this, or we could do that. And if we do this, this might happen, or this might happen. If you do that, this or this. And it's being presented now. The experiences that I'm hearing is being presented more in an objective way. And I think that if women have the information presented to them in that sort of very simple, clear way, they can then go home and work out where they feel comfortable in those risks, because all of our perceptions of risks and our experience, what we're willing to accept or not experience, is very different. And I think the removal of that, you need to do this, but here are the options. I certainly think clinicians would say, I think this is the better option for these reasons, or I would choose this for this reason. But ultimately the woman has autonomy to make that decision and to have time to make that decision. You know, think on it for 24 hours and come back. So I think the more we provide data and the more information we present in an objective, time relevant, in that benchmarking, where it's removed from the emotion, means that when you get to some of those conversations, you know, your baby's not growing, or we've got concerns that you've come in a few times now and your baby's movements have slowed, you've already had a lot of that information presented to you that you can say, okay, I do feel comfortable having an induction, or can I wait a few more days and have another check? And the woman there's no judgment, the woman's at the centre. So I think we're already doing it. And I think, you know, working with all of the clinicians, midwives, obstetricians, scientists, everyone, particularly in the stillbirth space, everyone is so passionate about empowering the woman to have the information and ensuring that, you know, the systems and the clinicians have best evidence, they understand the practice, they understand how to have the conversations, but the woman and her experiences and the family is central to a good outcome, I guess.
Well, in every pregnancy there's a mother and a baby, and I think that informed conversation and that informed decision making is crucial. So I think that's a really great way to end a discussion about research, what we're doing in Australia, what's happening, and having these experts in the room. So thank you, Leigh from the Stillbirth Foundation, for joining us today. Thank you, Vicki from the the Safer Baby Bundle, from the Stillbirth CRE for joining us. And thank you, Miranda from the Ritchie Institute, for joining us as well. It has been a very valuable discussion, and I know that there will be lots that the public and the community at large will gain from your discussions today, and understanding and knowing a bit more about what's happening in Australia for research for stillbirth prevention. So I really appreciate it.
Thanks, Claire.
Thanks, Claire.
Thanks so much, everyone. Bye. Thanks for joining us today, and we look forward to you joining us again next time. Remember, it's never too early to have a conversation, but it really can be too late. If you'd like to know more about Still Aware, the charity that's bringing you this series, head to stillaware.org.